Hi friends, it is time that the world is changing a lot. There's a new world order coming up. Taking it away, taking this phrase world order away from social and political scene, if we talk about medicine, it too is experiencing a lot of change. While until now, telemedicine was rather limited to certain aspects of robotic surgery, of certain other aspects of surgeries, remote surgeries, or to aspects of clinical investigations. In some countries, it was permitted for consultations. We see a whole new dimension emerging after the COVID scenario. While people have grown conscious and alarmed by fear of unknown, they prefer to stay at a distance. The changing scenario gives opportunity not just for e-commerce, not just for soft payments, banking, but also to doctors to work on, to present on assets which probably they otherwise, even in their clinical routine, do not practice beyond their lips, ears, and eyes on pieces of paper. Careful understanding of these objects, what we do within our clinical settings, gives us a careful and complete idea that actually we most of the time end up spending time over things in a fashion that we may end up doing using a camera, using a video call and material without having the person physically present. This implies that the person can be at his convenience, at his home, at rest, and it could generate a lot of possibility wherein physical transmission of any kind of infection to the doctor or to anybody in the setting within the hospital or the clinic can be prevented. Telemedicine comes in as a boon, as an offering that can support most of these endeavors except for surgery or something similar to surgery where a physical intervention isn't required. Now, when you talk of these things, there is something that has to happen between the patient and the physician. And this starts with some storytelling. The patient comes across the doctor, the physician, in his chamber, and much before that, sometimes in a clinic which is of some kind of a repute, he is faced by professionals who are paramedics. These people take stories, listen to stories, sometimes make notes, sometimes miss out on the notes. And then they bring those notes to the physician's table. At the physician's table, now the physician gets a fair bit of an idea as to what your complaint is. And it helps him narrow down to a certain perspective where he has specific questions to ask, and you also do not go on to generally talk about anything and everything that you talked over to his intern. Chances are that between the intern and between you, there was something that was missed. This something that was missed by yourself and the intern is significant. It is significant because it could be something that was of diagnostic value and the intern thought it wasn't. It was some kind of an allied sign, allied symptom, whereas it could have been the primary one, just camouflaging to be a secondary one. This distinction between what is primary, what is secondary, what is to be taken note of, what is not to be taken of note, is of clear importance. What happens usually when people record clinical history, especially interns, juniors, or paramedics, they tend to focus on medical terminology, medical jargons. And if I were to say that not only Hutchinson, but in most ways, wherever clinical history taking has been discussed, even in conventional sciences or traditional sciences or old medical sciences as Ayurveda, it is always said that record the notes and record them in the language of the patient, which means to say that you may not record the whole story, but keep away the jargons, keep away the terms, the terminology as far as possible, so that when the person goes back and has a look at the prescription, he is able to read as to what he told you. He finds what he told you in coherence with what you understood, and it then helps him understand why a certain lifestyle, a certain medication, a certain exercise has been given to you as an advice. As part of clinical history taking, there are certain elements that should be taken necessarily, particularly when it comes to Ayurveda. And besides name and age and gender, in Ayurvedic context, what is more important is the date of birth of the person, because that gives us a definition of how his Prakriti as per his age should be assigned. That should be his Prakriti as per the age as of today. What is the kind of transit that has happened? How Vat, Pitta, Kapha or Sattva, Tam or both have shifted, and what should the body present like at a certain age. Similarly, the place of birth, the season of birth, the mother's concomitant history of any medical conditions during or before pregnancy, which could be transmitted to the child. They all have been discussed even in Ayurvedic context, and they assume importance. However, it is always important to sequentialize and understand what is more relevant and what is not. You write upon your piece of paper or on your system and make notes basis of that order, but before that you must make a rough note, and that rough note will never be in order. It will always be variant, and this variance will come because the patient will tell you a story which will start from somewhere and which will end somewhere, and in between it would go here and there. It will, in some cases, not follow any sequential order. Sometimes you will have patients who will give references to incidents in the world, global incidents, to certain other things. Now, you don't have to get carried away by them. Say, for example, somebody says that he was born the year 9/11 took place. Now, he says it was the year 9/11, not the date 9/11. So, you don't have to be carried away. You have to be careful what date it is. Again, if you look at this clinical history with perspective of international patients, or even within a country like India where the geographical expanse is too big, you have to understand that the month of January is bitterly cold, say in Kashmir, a little less cold and chilly in Punjab, still a little less chilly in Delhi, but maybe down south it just does not. So, knowledge of topography, knowledge of geography, knowledge of climatology, knowledge of dietetics, basically. All these things combine together when you have to make a clinical history. Sometimes you may not know what the geography is about. Sometimes you may not know what the place looks like. But if you have all this relevant data of time, of place, of the geography, you can probably use internet as a tool to understand the place, the geography, the kind of food the person may be taking, the local produce of farms, and that just goes on to help you, that just goes on to add an edge to your diagnosis, because then you know what could be the areas where you need to work on. That also helps understand that what are the needs of the patient. Yes, sometimes this is very long, this needs a lot of time. Patient most of the time is prepared to give you all the time if you are looking to discuss the problem. It is very rare, and probably sometimes it is gender-based questions where you cannot be direct. Sometimes it is a question regarding sexuality or mental illness or so, where you cannot ask it so directly. But in a larger sense, you always can come back, you always can ask questions directly if you are in doubt. You need to win over the confidence of the patient, and for that you need to talk. When you talk, when you are able to generate that confidence into the patient that he can share what he is there for, he can also share what he is not there for, but maybe of your importance, because you can then judge the person psychologically as to how afraid or how well placed he is. Together, all this data comes together, comes into a pool, and you make of what is called a clinical history. Then these rough notes you can put onto a format you may have on a system or on a piece of paper, whichever way you do your clinical history taking. But you can sequentialize those events, sequentialize the changes, mark everything in an order, spend time over it. Yes, this is not outpatient department. This is not an OPD where you can just listen to the patient, push him off with a couple of scribbling lines on a piece of paper. But the moment you decide that you want to give your patient time, you gain his trust. The moment you decide that besides that time, you will take time to work on him, he will give you that time with all the patience, because he has told you the entire story. Once that is done, you have the patience, the calmness in you to nurture this important element, and altogether, all said and done, you make up for something that is important, that goes a long way. You have a format, or you can devise a format where you can just take these notes down, put them in order, and arrive at a conclusive diagnosis. This first lecture was basically about some very basic things that one needs to understand when taking a clinical history, especially during telemedicine, where people are not in front of you, people are not in physical distance of you. You are listening to their story over a phone call or a video call, and you want to have every piece of information that you do not miss, which means while the person speaks, while you talk, your hands must move on a system or on a piece of paper to acknowledge the effort that the person has made in discussing it over a call. The next step will be about understanding how these complaints move into the body's fittings. How do you fit them into the body? It will discuss anatomy. It will discuss a little deeper anatomy, to say how you assign anatomical ascribes to various conditions, various signs and symptoms that the patient may tell. And we'll then discuss also how the body's functioning as per modern medicine relates to those signs and symptoms. How can you correlate those subjects? And further on, there will be further other lectures. This is a 5-day series, and each day you will get some aspect of understanding how to take a clinical history when you are online. This takes health definitely beyond healing, because you spend time and gain trust of your patients. Thank you once again. See you in the next lecture.